The broadcast is now starting. All attendees are in listen-only mode.
Good afternoon, and welcome to today's webinar presented by HSG, Virtual Healthcare, Long-Term Strategies for Employed Physician Networks. I'm Terry McWilliams, Director and Chief Clinical Consultant here at HSG, and I'm joined this afternoon by Davis Creech, another HSG Director, and Kelly Humphreys, one of our specialist consultants for today's presentation. You may recall that we had a telehealth or virtual care presentation in the past several weeks, and this is building on that, and we'll talk about that in a second. And I thank Davis and Kelly for joining me this afternoon and presenting the next phase of this topic. Before we begin, we have just a few housekeeping items to take care of. Firstly, we want to re-emphasize that we welcome your questions. Please submit all questions via the Webinar Questions tab on your control panel, and we will answer as many as possible at the end of the webinar. We will not identify the names or affiliations of those submitting questions that we address to make sure that you remain anonymous. If you do submit a question and we cannot get to it during today's program, we'll be sure to answer it promptly via email after today's program. A video recording and slide deck for today's webinar will be sent directly to you via email and will be available for on-demand viewing on our website, hsgadvisors.com, by this time tomorrow afternoon. So with that, let's go ahead and get started with today's program by reviewing our objectives. So we hope that by the end of the program that you would understand the benefits of systematically incorporating virtual care in practice care delivery models, recognize that provider scheduling, compensation, and staffing norms may change, and identify strategies based on the anticipated future regulatory, reimbursement, and patient care environments. And as I mentioned a few minutes ago, this builds on our April 2nd webinar that's available at the link on the slide. So just a few slides of quick background that we presented back in April, just so that we're on the same page and have the same frame of reference. So for us, virtual health is a form of remote telehealth delivery in which the patient-provider interactions occur through telecommunications technology. There's both synchronous and asynchronous virtual care. In synchronous virtual care, the interaction occurs in real time, either through video teleconferencing or via the telephone or similar modality. In asynchronous virtual health, the interactions have time lags between responses. These occur commonly in patient portal messaging or via secure email or text messaging as well. There are numerous benefits for all involved with telehealth. For the patients, there's greater convenience in both timing and travel. There can be greater access to both primary and specialty care than awaiting face-to-face visits, and at least theoretically lower costs. And perhaps there is that, so for instance, CMS has indicated that they would expect the patient to have their same copay and meet deductibles. So there may or may not be lower costs for the patients overall. But if you think about travel and parking and all those elements, total costs for them tend to be lower during virtual care visits. For providers, also greater convenience with more flexible scheduling and time management. There can be improved access to patients because, we mentioned transportation as a barrier, but there are other barriers, including finding convenient times, et cetera, to get patients and or their caregivers into the office, and potentially a greater access to consultants in that if we are able to reimburse our consultants for formal and informal advice, then perhaps they'll be more amenable to those conversations. For administration, there's decreased cost of care and increased operational efficiencies if the business and clinical operational processes are tailored for this service. Virtual health has had a number of historic or traditional barriers to utilization. Reimbursement in the fee-for-service environment was a primary one for most entities, and that reimbursement varies and varied by payer. Patient acceptance has been a barrier. Provider acceptance has been a barrier. Having secure mechanisms to telecommunication mechanisms to provide virtual health that adequately protects patient privacy. And this was a concern even in the pre-HIPAA era, but especially the concern of complying with all the HIPAA regulations weighs on many providers' minds. The availability of technology for both the provider and the patient, and being able to use the technology, which can be a challenge for all of us, for sure. What we found with the COVID-19 public health emergency is the pandemic created interventions that included social distancing, canceling elective office-based encounters, the need, not just the desire, but the need to conserve resources like PPE, and then accompanied by relaxation of regulatory restrictions and greater reimbursement, allowed everything to kind of take off and explode. It seemed to be acceptance born out of necessity as opposed to the desire to adopt the technology. As we look at what's changed with some of the barriers with virtual health with the COVID-19 pandemic, various surveys have shown that upwards of 40% of patients like the idea of being able to have interactions with their providers without the hassle of going into the office, commuting, taking time off from whatever they were doing and making their way in. And a similar number liking the fact that they can have provider interactions without the concern of being in waiting rooms and being around others who might be ill and might pass their illness on to them. This is a huge issue, especially coming out of the heavy restrictions of the COVID-19 public health emergency, where there is still, at least we're experiencing in these early phases, still a large percentage of patients who are somewhat uneasy about what they might be exposed to in the office or hospital environment. So we expect that this number would actually be a little bit higher based on our experiences and likely continue for at least a number of months. Similar surveys indicated that patients have increased confidence in the ability for telehealth to meet their needs, with more than a third indicating a preference for telehealth interactions, whereas almost a quarter indicate they don't believe telehealth will ever match the quality of an in-person visit, and a similar number wonder, if they're really getting as good a care as they could in an office-based environment. Similarly, I think we have all, and I could defer to actually I will ask my colleagues, but from the provider side, it seems that providers have been less reluctant to embrace telehealth because of necessity. But when we talk about the future with them, the old barriers of, gee, I'm not sure that what we offer in a telehealth environment will ever equate to what we can do face-to-face, even for simple interactions where we review results or plans of care without actually laying on of hands. And I get the impression, at least from the providers I speak with, that as things, quote, return to normal, I'm not so sure that as many, with again upwards of 70% of currently active providers embracing telehealth, I'm not sure those numbers will persist. And Davis and Kelly, I'm wondering if you have similar impressions on both the patient and provider side.
Yes, sorry, I think I was on mute. Yes, the clients that we're talking to, the providers are seeing this as somewhat temporary and not sure it's here to stay. A couple of things going on there. One, we're not sure what the payers are going to do, and two, we're not sure what the patient population is going to bear and necessitate. And I think you're going to talk about the latter later in the broadcast, but Kelly might be able to answer a little bit more on the former with the payers.
Thanks, Davis. I have seen a significant swing by providers over the course of the last 90 to 120 days. Those that were absolutely, I can't treat a patient without laying hands on them, to, okay, maybe I can. And payers who said, we are not, telehealth is not something we're going to embrace. And they are now embracing it out of circumstance. But I think that they are going to have to take a real hard look at how they're handling today's environment as they move forward in re-implementing their limited access to telehealth. Because I do believe that our patient population and our general population as a nation we're going to look back and say telehealth does have a place today that we didn't really realize prior to March 13th.
Yeah, so I think I agree that I think there is a uniform impression that we can't go all the way backwards to where we were before, but I don't think we're very settled on how far we're going to go back, and I agree with both of you. It depends on so many factors. And maybe we can address some of those because, what does the future hold and what can we look forward to? And those aren't just semantic questions. I think, as Kelly, as you mentioned, the world's changed with all the permissions and waivers coming out of CMS and the federal government. How much of this effort to promote telehealth as an alternative to in-person care during the pandemic, how much of that will continue? And that's a question that many of the providers have. And let's go down through some of those and some of our conjecture. So what we do know, and this is as close to quote fact as anything else, the types of virtual visits that were codified in the 2019 and 2020 Medicare Physician Fee Schedule final rules will continue to be recognized and reimbursed by Medicare Fee-for-Service. I think that's an absolute given because it's out there in regulation, and I don't think they'll go backwards. Weirdly, CMS does not consider these interactions to be telehealth, even though it fits in the broad definition of telehealth, which is another reason that we have preferred the term virtual care or virtual health as opposed to trying to put these interactions into the broader telehealth, telemedicine nomenclature. So CMS does not consider these virtual visits to be telehealth and will continue to reimburse for virtual check-ins, e-visits through the patient portal, the store and forward communication, which utilizes images and videos, the interprofessional internet consultation, which reimburses consultants for offering opinions in patient care that were not previously reimbursed. And these are impressions that do not require face-to-face interaction with patients. The whole chronic care remote physiological monitoring world, and one of which is self-measured blood pressure treatment plan support. So these have been codified in regulation, and the absolute rules are there, as well as reimbursement and RVU credit. I would refer you to our earlier webinar because we talked in some detail about these, and we won't go back over there. But these will continue. They were present before COVID-19, and they will exist thereafter. Here's just a quick chart comparing the office visit, some common E&M codes for established patients and their RVU credit with associated provider time compared to those already approved CMS encounters. You'll notice that there is considerable discrepancy between a face-to-face office visit and what's being paid for in the virtual health codes, at least on the Medicare fee-for-service realm. And this has been an argument for, I'll just say, physicians that I've spoken with and who live in the fee-for-service market. They say, well, convenience be darned. They may not have used darned, by the way. But if in a brief encounter in the office, we're going to get reimbursed, for upwards of $46, and I'm going to get almost a half of an RVU credit for that 10-minute encounter. Why would I utilize, for instance, an e-visit interaction? Why wouldn't I just have my staff have the patient come in if they initiate that contact? And I can be paid much more handsomely than I can get with a similar time expended. And again, Davis and Kelly, I think this mirrors what we've been hearing all along about the discrepancy between in-office encounters and the world of telehealth reimbursement. Is, even if CMS is trying to recognize this, it's not until they got to the point of reimbursing the same way as they do for office-based encounters for a telehealth interaction that people really started to stand up and take notice. Would that mirror your impressions?
Yes, it would. The providers were much more accepting of the telehealth and were much more open-minded about it, as we explained that you're going to get paid the same and we're going to look at things the same way. Many of the comments that I heard was, when I'm on a telehealth visit with a patient, it's going to take me much longer because the only thing that patient can do is talk to me, and we're going to have to talk through everything. Where if I'm laying hands on a patient, I'm asking questions, we're going through that. I'm looking at a typical 15-minute visit being a 30-minute visit or a 25-minute visit. So once there was an understanding that you're still going to be reimbursed for that time, and you're going to be able to talk through things a little more lengthy and get that reimbursement and not have those reimbursements cut, many of my encounters with providers changed drastically at that point in time.
Yeah. So as we look at what organizations have done during the pandemic and what we need to do coming out of it, looking at our processes associated with virtual care, we have the opportunity coming out of it and looking to the future to make sure that we define standardized processes for the interactions that occur and fulfill the various requirements. And I know that this has been a huge challenge for many practices to make sure that the documentation adequately addresses the requirements to make sure that we can support the claim submissions. And I've been told that coders and billers have had significant difficulty themselves keeping track of all the variables and all the requirements and communicating that to providers and having providers fulfill all the documentation requirements, which then gets down to considering development of templated formats in the EMR to assist that compliance and to be able to withstand an audit if one should occur. And again, as we look out from the COVID-19 timeframe, there's very little risk of an audit, but CMS has said there's little risk of an audit right now, but going forward, our processes have to support the documentation requirements to make sure that we're meeting the billing requirements. And Kelly, you and I have talked. I mean, you've also said telehealth requirements are changing daily. The environment's changing daily, and keeping up with it, but also making sure providers are well abreast and the support staff are well abreast of the changes and requirements is really a challenge, isn't it?
It is. We started with our telehealth programs, mid-March with a outline of the services and how they were going to be handled from a reimbursement standpoint, and then we'd get things moving forward, we'd get the coders on board, we would get the providers educated, we would get our systems built to support that process, and 2 days later we would get an update from a payer that said, oh, just kidding, you don't have to put the provider's address on your claim form. So now we're backing all of that out. We're starting, so it's been ongoing, and it still is, all the way to, behavioral health has been a very significant issue. It presents its own set of unique circumstances. We want to make sure people have access. We do a lot of group telehealth in healthcare, so it has just been an ongoing daily touch point to ensure that we are working on the most current set of rules that have been published. And in one of the organizations I work with, we have a standing weekly meeting to go over any changes, system requirements, payer changes, just to try to keep all of us moving in the right direction. So it has definitely taken a village to keep telehealth up and moving with all the changes that have been going on.
Yeah, and I think this middle bullet is particularly germane in that the current telehealth codes are really based on provider-patient interactions, and these interactions cannot be fully delegated to support staff like we have for some of our in the past with some of the telephone consultations. It's an interaction with intermediaries, and tell them to do this and tell them to do that. This has to have a provider-patient interaction, although involving support staff can make the whole process rendered more efficiently, from obtaining background information to making sure that technical aspects are in place, to teeing up the patient to make sure the patient knows what to expect and can utilize the technology, and arranging things for a specific time for synchronous interactions, and connect the provider and patient to make sure things flow smoothly for all parties. So even though the interaction needs to be very specifically a patient-provider interaction, being able to efficiently and effectively utilize our staff to make those interactions the best possible, just as we would for an office-based encounter, is very critical. Back to the comment of having a virtual visit take twice as long as a face-to-face encounter, many providers were just entering into the virtual care interaction kind of blindly, right? As opposed to having the staff tee it up like they would a normal interaction, make sure the patient was well prepared, have everything smoothed out, and then the patient provider interaction can be both efficiently carried out and effective. And as the machinery gets put into place and it becomes well oiled, many organizations have found that the virtual care interactions take much less time, much less provider time, as well as much less support staff time than the face-to-face encounters, and therefore become much more cost effective over time. I'll leave it there. I was going to go further, but I'll leave it there because we'll talk about that in a second. So, with looking to the future and looking at provider scheduling, how will we conduct virtual care in the future? Would we expect providers to do this outside of normal business hours, as we have for things like, previous telephone messages and portal messages? Will we schedule blocks of time to address this? For instance, at the end of the morning or end of afternoon. I know in the past, many practices said, we'll return, your telephone messages, between, say, 11:30 and 12:30 and 4 and 5 in the afternoon, and patients knew when to expect a call. Will we schedule time in each office hour? So perhaps blank appointments or virtual appointments scheduled within the hour to break up the face-to-face time and virtual time. How will the scheduling process be modified as we look at this long term and have to really balance our face-to-face encounters with our virtual encounters? And then looking at, will we utilize the interfaceable home monitoring devices to do things like regular glucose monitoring or blood pressure monitoring or daily weight monitoring, and can these then directly populate our EMR to decrease the manual entry issues that we face on a daily basis. And so there are opportunities to look at these and figure out how we can incorporate these into our daily practices. I know especially the latter has not gained as much traction as the former. And during COVID-19, we basically were all about our patient care time being virtual because we had very little face-to-face time. So as this changes over time, we need to look at those dynamics and figure out in advance how we'll deal with it. And this might be a good opportunity to interject. When we talk about making these decisions, we're not talking about making them in a vacuum, but having discussions with provider leadership, involving provider leadership councils, looking at how things need to go moving forward, and just not blindly making decisions based on what we individually think might be best. And Davis, I know that you were sitting there waiting for me to say something about that, so I figured I'd do that now, and maybe you can breathe more easily.
Very well, very well.
Okay. So what do we know about the other telehealth interactions? CMS's telehealth regulations originally were more consistent with traditional telemedicine delivery. They were limited to designated geographically rural locations, which CMS expanded during the public health emergency, and there's popular support for future regulatory change to include all locations of care. If we really want the spectrum of telehealth to be available and to be utilized as a foundation of patient care in the future, it can't be limited to just the rural locations. With the original regulations, the originating site, also known as where the patient is located, previously had to be within a healthcare facility, again, consistent with the telemedicine delivery of care. And CMS permitted the patient location to be at home or anywhere the patient was at the time, whether home, work, in a long-term care facility, etc. And again, there's popular support for this as well. This permits greater patient convenience, assists with transportation issues and other barriers to care, and there's a groundswell of support for allowing the originating site to be other than within a designated healthcare facility. The distance site, or where the rendering provider is located, the requirements in the past was that provider must be licensed in the originating site state and possess clinical privileges in the originating site facility. During the pandemic, CMS waivers included permission to provide care in states in which the provider was not licensed so that we can maximize access to healthcare resources. And CMS ultimately indicated using the, Kelly below this, the POS code for telehealth interactions, indicating that the care was rendered in the office, so that that whole dynamic of where's the patient and all kind of disappeared. Did I state that well enough, Kelly?
Yes, the place of service has been quite a challenge over these past few months. They indicated that you use one code for certain telehealth codes, you use another code for other telehealth codes, and then they finally just said, okay, look, we're really confusing you, so let's just use the office code and we'll just act as though everybody's in the office.
And I think there's a lot of popular support for continuing that mode of thinking. So if the intent was, I would be seeing the patient in the office if we weren't doing virtual care, then perhaps we can just kind of pretend that all care that I'm rendering would be in my office if we had the opportunity, or if we wanted to impose that on the patient. And so maybe we can decrease some of the complexity of licensure and privileging to just be pretend I'm in the office and I'm interacting with the patient in my office, no matter where I'm located, no matter where the patient's located, and let's just make it much more simple. It's almost a KISS approach,
Mm-hmm.
you know, the keep it simple, stupid approach to having this, and it makes all those various facets of complexity disappear.
Mm-hmm.
Do you think that there's much appetite with CMS or the commercial payers to follow that train of thought?
I think that as we move forward, it's going to become a more restrictive, that the codes are going to be more restrictive, because at this point in time, there was no way to effectively identify where providers were, where patients were, and was it telehealth, was it not telehealth. I think that we will see things change to where it is a more static code. So if we're actually providing telehealth, we're using a place of service telehealth, regardless of where the provider and the patient are, instead of using the office. I think there's going to have to be a distinction. And the logic is that if I'm providing a evaluation and management code via telehealth, the payers want to know that. If I'm providing a telephone visit, the payers want to know that. So why wouldn't we use a place of service that indicates that that encounter was a telehealth encounter, opposed to always using 11 or always using 02. So I think that there will be some thought given to it. And I think that we're going to have to come up with a logical method of identifying when a service is truly performed via electronic means. But I think that they're going to look at it in a more logical sense than throwing, 8 or 10 different codes at it.
I'm not sure I'd be able to handle that if they were really trying to make it more simple and straightforward. But kudos.
Yeah,
that was very sarcastic.
I certainly hope that with all of this, that HHS, CMS, and all of the payer organizations who have, sat around forever and ever and said, okay, so what are we going to do next? And how are we going to do this? And let's put regulation on it, have recognized that there's just a point in time when we need to let logic prevail.
If we look at permissible interactions, CMS expanded the list of permissible patient encounters during the pandemic to cover most face-to-face encounters. And for them, a huge late addition to the list was adding the telephone encounters, 99441 to 443, which they never they recognized that they were valid codes, but never reimbursed for those codes. Nor did many of the commercial payers. But at least during the COVID-19 timeframe, CMS equated 99441 to a 99212 for reimbursement and RVU credit, and you can see the other correlations to 213s and 214s. There is a distinction to be made between the virtual check-in, which is a 5 to 10 minute interaction where response can be by any mechanism, even if the patient initiates it by telephone, as opposed to a straight telephone interaction on the provider side. And Kelly, from what I'm hearing around is that most individuals don't really think that CMS will continue to recognize these codes as reimbursed. And in fact, a couple of clients that I've interacted with over the last couple of weeks indicated that commercial payers are already indicating that they will no longer pay for these codes in the very near future.
I agree with you. I haven't seen anything specifically from the commercial payers. I do know that we have had some significant challenges getting payment for these codes. I don't anticipate that they will be, they're going to be sunsetted as quickly as possible. And honestly, in the sense that they're used, it really is a disservice to the provider in a lot of circumstances to use a 99442 code if they're providing particularly a behavioral health or an addiction counseling service because the patient doesn't have access to anything else, and they're talking to the patient for 60 minutes because there's no way to get paid for 60 minutes.
Yeah. Great points. Reimbursement rates, again, we showed the table that showed the codified rates that the persisting types of interactions have. CMS, as we mentioned, is reimbursing virtual interactions and in-person rates. Again, most do not feel that that'll be a long-term by either CMS or the commercial payers. And we already mentioned what comes back from the providers in that regard. I think, part of the reimbursement rate determination for virtual care takes into account that there's less overhead associated with those interactions. The bricks and mortar stuff, utilities, and those kinds of things that are reimbursed with standard care do not exist with virtual care. So having identical reimbursement rates probably is not feasible or able to be expected for the long term. Similarly, since the perception is out there that many virtual visits are involve less complex medical decision making, do not involve significant physical exam interactions, that the RVU credit should be less than a face-to-face encounter. However, there may need to be some adjustments in that realm, especially with many compensation plans being RVU based. So again, reimbursement rates are fantastic during COVID-19. Most people feel that they won't be nearly that rate, even if there's some changes coming out of the pandemic. Similarly, the telecommunications technology waivers and not being absolutely concerned about HIPAA compliance, allowing video communication through Zoom or Skype or those kinds of things are felt to likely not persist in the post-COVID era. That secure communications, especially with video linkages, will need to comply with HIPAA in the post-COVID time. I know a number of organizations have explored options that are available through their EMRs, and many had not pursued these previously. Others are exploring separate platforms with business associate agreements for these interactions. Some who have the EMR capabilities find that they're not sophisticated or as sophisticated as other platforms. And even though they're directly linked to the EMR, the other interfaces allow direct to the medical record assimilation of information. So looking at what might be the best post-COVID option for video communications is something that should be thought of now and allow this time to effect transition into where you're going. And back to patient portal, we've encountered numerous organizations who just have not used the patient portal to its maximum extent, and this is a good time to transition to rolling out expanded portal services to patients and to encourage their use. We mentioned earlier in this presentation that CMS expects Medicare copays and deductibles to apply to virtual health encounters. During the pandemic, CMS permitted provider discretion to reduce or waive the fees. This is not likely to continue because of the concern that was in place in the past, which is these are services for health, and offering services at no cost to the beneficiary was akin to offering a kickback. Come get care with us. We won't charge you your copay or deductible, and will be good for that. So that aspect of the relationship would be unlikely to continue post-COVID. If it did, there'd be a lot of people who would be very surprised that those waivers were continued. The CMS original telehealth regulation indicated that these interactions are for established patients only and not new patients. CMS waived, well, they didn't really waive. They just said they wouldn't audit to determine if the patients were established or new, during the pandemic, and therefore virtual care could be appropriate for all patients, whether you had an established relationship with them or not. I think most people anticipate the CMS will return to the established patient designation after the public health emergency is lifted, but that remains to be seen. So what if CMS, Medicaid, and commercial insurers yielded to provider and public pressures about some of these things we just talked about and revised the regulations or their parameters for use of office-based virtual care to permit application to all practice locations, application to patients regardless of their location, so they could be at home or at work, providers to be considered in the office when providing virtual care with simplistic coding applied, and eliminating the need for licensure and privileging for the site or originating site. And this is particularly pertinent for organizations that are around state lines, where many patients cross the state line. If I'm essentially providing this care virtually as if I was in the office, then perhaps we can just worry about office location. Maintaining utilization for all types of patient interactions that were permitted during the pandemic, and reimburse at the same rates, and I think the provision here is minimally discounted rates as in-office encounters, recognizing that there may not be as much overhead, but as much provider effort, so perhaps not as much of a decrease in the RVU credit as we saw in that earlier table. If that did happen, perhaps that will continue to remove many of the barriers to that might crop up again, and prevent us from continuing to incorporate virtual care into our daily office practice after the pandemic. I feel that even if the requirements for HIPAA compliance, the charging copays and deductibles, and applying to established patients still apply, which were those things we didn't think would change, even if we address the other barriers, we're going to have enough difficulties with provider acceptance and patient acceptance, coming out of the necessity to, it's just a good way to provide care safely and effectively and more conveniently for all involved. What if all that happened? What if we were able to address those things? What if we could address the technology barriers? And I would particularly point to the third bullet about internet speeds. Huge variability in internet connectivity and internet speeds across the country. Not so much in the urban areas, but getting away from urban to suburban and rural, internet speeds are an issue. And within some of the recent COVID-related legislation was the obligation of, I think it was $2 billion working on the infrastructure across the country to allow greater broadband access and greater internet speeds to allow telehealth to be more of an option across the country. But looking at utilization of it, expanding the patient portal and utilizing it, and recommending utilization of it for both patients and providers, and looking at increasing our connectivity. So if we did all that, what would that do to our clinical operations and care delivery model? How should we best incorporate virtual care into daily clinical operations? We talked about creating operational processes or modifying current ones to ensure maximum use of virtual care to enhance patient-centric access to care. We've talked a lot over the last several years of patient-centered care, Sometimes patient-centered care becomes more of a concept of we will comply with patient-centered medical home concepts or patient-centered specialty practices. But in thinking patient-centrically, it's putting the patient at the center of our thought processes and becoming more patient-centric than provider-centric, even though there's benefit to providers as well. Looking at how virtual care can augment care for minor acute care, subacute care, and chronic care, so the patient needs can be anticipated and met in the most convenient manner. Perhaps a mix of virtual care and in-office care to make sure that we address all the elements that need hands-on care, but maintain interactions and supplant some of the in-office care with virtual visits when allowable and preferable. How does that affect the scheduling of both providers and our clinical support staff to maximize the efficiency of virtual and in-office care? Do we do interfaceable monitoring capabilities rather than relying on the patient manually recording, bringing it in, and the staff manually inputting the information into the medical record? And how can individual talents be best utilized in this whole process? We all have various strengths and opportunities. So how do we design a system that can incorporate virtual care and yet maximize individual talents? And that also gets us to maximizing the acceptability for all. You know, we talked about provider and patient acceptance still being potential barriers. And again, the experience has taught that if we treat virtual care interactions as if we're rendering the care in person, then we stand the greatest chance of having quality virtual interactions and having both providers and patients feel like the interaction was not only worthwhile but very effective and very efficiently delivered. So we should choose interactions wisely and appropriately to best utilize time and effort. We should be prepared for the interaction just as we would for an in-office encounter, both the patient being prepared with the help of support staff and the provider being prepared with the help of support staff, but also reviewing the record and being ready for the encounter so that it's not just an off-the-cuff experience. I found it interesting that a couple of articles recommended that you smile for the encounter even if you can't be seen. So even if it's not a video communication, but it's just a telephone interaction, if you smile during it, it tends to come through in your voice inflections. And I didn't believe it until I tried it one time, and it can make a difference. It's just your whole countenance. It can be different if you're frowning or smiling, and it comes across in the voice. Engage the patient directly and be present and attentive in the interaction. It's sometimes very easy in these to look at other things on your desk or other things on your computer screen and not be present and attentive, but focus on the interaction just as you would if the individual was present in front of you. Many individuals write about and have found that if we drone on about educational explanations, we turn into the Charlie Brown teacher experience where it goes wah 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 wah, Mrs. Jones. So if we can keep the educational explanations brief and break them into digestible pieces and even split them into successive briefer interactions, you know, okay, let's talk about this first one today, and maybe we'll schedule a virtual visit in a week and we'll go over part 2 and then subsequent parts. And it tends to be much more digestible and able to be assimilated into their thought processes. Determine and convey agreeable follow-up plans, just as we talked about, virtual or in office, and what we anticipate happening in between those encounters, just as we would for an office visit. And then I just can't let this go without saying the repeat verification process is even more important in these interactions. If we're not doing video communication, we don't have any of the nonverbal cues to take in. So asking individuals to repeat back what we said really will convey understanding. the degree of connection that we had, we have to really consciously think of doing that as opposed to just saying, okay, thank you very much, we'll talk again in 2 weeks. So I emphasize that for sure. And then in this whole process and delivering, modifying our care delivery models, being sure that all staff are on the same page with a standardized approach, common understanding, and that we all know how we will use this to interact with patients. We're all positive in conveying it, and we all take similar roles in the process of the patient interactions. On the business side, as reimbursement changes, will a practice confine itself to virtual care that is reimbursable by third-party payers? Or will you consider implementing virtual care for a flat rate? And there are many commercially available companies that offer these services, especially for acute care. And it's $35 up front on a credit card, and you have your interaction, and you go about your business. So if we are going to continue virtual care as part of our daily operations, how do we do it, and what do we want to target it for? How will the copays and deductibles be collected if they aren't in front of us, but we have to take that? Will we initiate credit card interactions at the start or conclusion of the interaction? Do we pursue delayed billing, which Davis, we know that the collection rates of copays and deductibles after the point of service is a difficult thing, is it not?
Even in non-virtual situations, just to be able to collect copays at the point of service, either before or after, particularly we would hope in best practice before, but it gets even more challenging with this.
Yeah, and so the couple of challenges. I mean, the first is having staff be comfortable with collecting the copays. Some staff are not, even though it should be an expectation up front. But the other is the mechanical pieces. In the office, we've developed ways to be able to accept credit cards for payment. If we're going to have long-term virtual care, determining how we can incorporate that aspect of payment can become a significant issue. At least I think so. We talked a lot about the documentation, billing, and coding issues and how we might address those. Kelly in particular mentioned, keeping track of everything, making sure all the documentation matches the requirements, and that we submit the proper codes with our claims is a tremendous aspect. We've found that developing EMR templates to help with encounter no completion and making sure that we have addressed all of the particulars that are required, including time of duration, the provider involvement, etc. And having coding educational programs and point of care aids to make sure that we've covered those areas. But more importantly, I think, just based on experience, and Kelly, you're a great proponent of this, is having effective bi-directional communication and feedback between office staff, the providers, and the traditional revenue cycle staff or the centralized billing office staff to make sure that we're all on the same page and going in the same direction. And Davis, this is a hallmark of a lot of the work that you do with practices as well. I'm not sure if you guys want to expound on this more at this time, or if we've beaten that horse enough at this point.
I don't know that I can add anything specific to the documentation, billing, and coding. Kelly is living this on a daily basis at one of our clients, so I will defer to her.
Well, thank you. Yeah, I can't emphasize enough the importance of having that communication and just developing those committees or those teams that help to monitor and manage all aspects of this piece of the practice. There are so many moving parts, and One thing that we haven't bullet pointed that I do want to bring out are consents. That is an area that some of my colleagues have spent a tremendous amount of time working on, because the telehealth does require a consent. The general telehealth, and when I say general, clinic telehealth, requires that a patient consent to that annually. However, behavioral health requires a consent for every visit. So it is just paramount that there is good communication within the organization to develop the processes to be able to capture that type of information. I think that we will be provided some grace with our current circumstances, but I do believe moving forward, as the landscape changes and telehealth takes on potentially a different flavor in our healthcare environment, that consents are going to be our gotcha. The first question, okay, we'll pay for the telehealth visit. Do you have a consent? Well, no. Well, then we're not going to pay you. So those types of communications, having those tools in place now, sooner than later, communicating with your vendors, identifying who's responsible for capturing this data. Again, I could talk for an hour about all of the particulars surrounding the events leading up to and the events after a telehealth visit to ensure that A, the patient has a good experience, B, we are regulatorily meeting all the guidelines, C, we're getting paid for the services that we're providing, and D, we can go back and we can quantify what it is that we're providing.
Excellent. I was going to say that for those of you who'd like to stay tuned, Kelly will talk for the next hour about those aspects.
No.
No, thank you. And then finally, marketing the service, right? So both within the practice with signage and staff interactions with patients, and having become part and parcel of the fiber of patient care within the office, but also marketing externally to try to differentiate, I can't say that anymore, differentiate yourself within the market. Just as the commercial entities are advertising and marketing their telehealth and virtual care capabilities, getting that word out that you offer the same, not only during normal business hours, but perhaps after, will differentiate you in the market and may lead to greater patient capture and greater patient retention. That's a nicer way than saying maybe you won't lose patients to others who are doing it. Exploring options for reimbursement with commercial insurers. We've mentioned several times that it varies across insurers. The insurers are looking at bending the cost curve as well. CMS has been driving the wagon to get us into more accountable care. We were accountable for the total cost of care, and moving toward a full risk, which is most notably present in a capitated environment. So if we're all moving in that direction, trying to get all the commercial payers on board as we work on our contracting becomes an area of opportunity, and ensuring that we are adequately reimbursed for virtual care can be part of that. Looking at the impact of virtual care on provider compensation models, do we need special considerations for this? Are there some virtual interactions we want to support, but maybe the RVU credit isn't up to what our productivity models, our productivity-based models require? Do we need to revise our models to be able to account for these changes? What's the impact on budget, and do we need to modify our strategic plan to have virtual care be more prominently displayed in each of these? Lastly, wanted to mention some resources that are out there so you don't have to try to reinvent the wheel or do it on your own. I tried to be very non-commercial in this. So CMS has a telemedicine toolkit. It's available online, and it's a collection of resources from multiple sources covering the basics, covering vendor selection process and potential vendors, having technical assistance and review of CMS policy. There is a special section related to COVID-19 but almost all of this toolkit is pre-19 and will continue to be valid post-COVID-19, and is pretty reasonably there. I was going to try to be very sophisticated and go off of this presentation and pull up the website to show it, but I don't think I want to take that risk. So I would encourage you to look at the site. It does have great information. HRSA and through hhs.gov also has a telehealth area. It has information for both patients and providers. So there's an opportunity to explore both elements to see where resources might reside for both your patients and for you as an organization. The elements are across the continuum, but includes legal consideration and has a number of reference materials at the end as well. And again, it also links to multiple sources. And then the AMA has a telehealth implementation playbook. It's better than 100 pages, and it's everything, soup to nuts, from developing programs to start to finish, evaluating success. It has a whole host of forms that can be utilized in the process for various aspects, including evaluating success, and has other resources for consideration. I mention these because we feel that we should provide practical, sustainable solutions for individuals. We also don't feel that while we would love to have your business, we don't want these webinars to be sales pitches. We want to inform, and these resources are excellent sources of information that can help you in your virtual care journey. So with that, we'll conclude the formal presentation. I won't go over the various conclusions. We hope you would, though, we hope we have met our objectives with this, and we hope that you'll conclude that virtual visits do offer longer-term care delivery alternatives and many benefits to consider. So with that, we'll look to conclusion for questions. Actually, we're 2 minutes beyond our time. Let me just quickly look for questions. There is one question, but if it's all right with the panel, maybe I'll follow up. We can follow up by email with that question afterwards, considering the time. Would that be okay, Davis and Kelly?
That works for us.
All right. We'll do that. And for the person that submitted a question, we'll get a response to you within the hour, and we can open a dialogue that way. Did want to mention an upcoming webinar in 2 weeks. Eric Andreoli and I will be talking about advanced practice provider employment options, compensation model options, and utilization parameters. We hope that you would join us for that. You can register right now on our website for that. And again, as we mentioned earlier, a video recording and the slide deck for today's webinar will be sent to you directly via email and will be available for on-demand viewing on our website by this time tomorrow afternoon. Well, thank you very much for participating, and we hope everyone has a great day and a great weekend ahead. Thank you very much. Bye-bye.
Thank you. Thanks, Terry.
Thank you. Bye-bye.